Thank you. So the first session is centered around cataract surgery, and it's a very relevant session because cataract surgery happens to be the most commonly performed surgery worldwide. Not just most commonly performed, but also one of the most successful surgeries worldwide. And what defines success? Of course, safety. But if we ask patients what is success, there are three things which are very important to them. That's the absence of discomfort, quality of vision, and refractive outcome. And refractive outcome is indeed very important. If we look at this study from Schallhorn, a residual spherical equivalent of just 0.25 diopters increases the odds of dissatisfaction with 25%. And that, of course, brings us to IOL calculations, where we want to predict the ideal power of the lens we want to implant. And what factors are important? That is the effective lens position, where exactly this lens will be positioned in the eye. The corneal refractive power, cornea being the most important refractive element in the eye. Axial length. And then, although it's an old formula, it makes sense to look at the SRK formula, which says that the power of the lens is A minus 0.9 times K minus 2.5 times axial length. And immediately we see that axial length is indeed the most important parameter. Axial length, which can be measured using ultrasound, partial coherence interferometry, or OCT. But with modern devices, I think there is a practical limit reached to the accuracy with intra-class correlations, and we will see that also in the study, above 0.99. So axial length is no longer really an area of competition. A, which represents many things dependent on anterior segment parameters, ACD, K, which we'll see also later in the study. And then, of course, which is that made the difference between the different formulas estimating the effective lens positioning. And then the keratometry, which although only has a coefficient of 0.9, if we look at the difference between devices, we see that for axial length, the agreement between devices is very, very high. In this study, 0.03 millimeters. But the difference between devices on K readings is much higher, 0.18 diopters in this particular study. So even though the coefficient of the axial length is much higher, in practice, keratometry is where the difference is made between devices. And when we compare biometers, typical biometers are an axial length measuring device with some kind of keratometry put on top. And the MS-39, of course, is the exact way around. It's a keratometry device with axial length now added. Just for keratometry, it's not a fair comparison. For example, comparing the IOL Master 700 to the MS-39, Francesco can tell you everything about it. But just looking at the number of points being measured for keratometry, for the IOL Master 700s, it's only 18. For the MS-39, it's well above 30,000. So in this study, I compared the clinical impact of using the IOL Master 700 versus the MS-39 XL in real-life patients. But before I go to the study, I have a question for the audience and the panel. Who is familiar with the term vibe coding? I see some hands here. Everyone actually should have risen their hands because it was from the Collins Dictionary voted as the word of the year 2025. And vibe coding is the process of describing what you want to code to an AI, just in plain language, and then the AI does the code for you. In the last couple of months, there have been dramatic improvements, and now it's estimated that over 90% of all code written by coders is actually written by AI. Now, vibe coding would imply only code, but it's much broader. It's the process of describing anything you want to build, to analyze, whatever, to an AI in plain language, and then the AI does it for you. And that's the switch between just asking a question to AI versus agentic AI. And I think 2026 will be the year of agentic AI, where you give a task to the AI and it completes it by itself. So the results of this study are all the result of vibe coding. I gave a very long prompt to my computer, had some back and forth discussions, and then we agreed to an actionable plan where we would have 3 agents. First agent would do the data analysis, then another agent in the meantime would perform a literature review, and then the third agent would write the article. Data analysis, I had 3 different data sources, a raw export of all my patients, of the IWellmaster 700 and the MS-39. Then I said to match all those patients, to find the patients who had surgery and who had received both IWellmaster 700 and MS-39, to pull the surgery details, date of surgery, type of lens implanted, power of the lens, then find the post-op refraction at least 2 weeks after surgery, run automatically the Barrett Universal 2 formula for both devices, and then compare the results between the 2 devices. In the meantime, the literature review agent would perform a literature review, define the research scope, search on PubMed and Google Scholar, screen select studies, summarize the key findings, and structure the background. And then once the first 2 agents were ready, the article writer would receive the input from both agents, write introduction and methods, present the results, anchor the discussion, and then deliver a journal-ready draft. And this was the result, complete PDF, layout, everything, with the purpose of the study to compare the refractive prediction accuracy using the Barrett Universal 2 using the MS-39 versus the IWellmaster 700. We only analyzed the, and I don't know if it's readable, but we only analyzed the non-toric IOLs. In the end, we had 40 eyes of 34 patients. Again, I'm not certain if it's readable, but yeah, it was a fairly normal population, mean age 65. The majority of lenses were trifocal or EDOF lenses. And if we look at the raw measurements, so axial length, K readings, etc., we see that the intra-class correlation for the major parameters, axial length, K readings, etc., is well above 0.99, what we knew from other studies. Wide to wide only was 0.7 something, and we know that from ICL surgery that there's a large difference between devices, especially with the IWellmaster. Then lens thickness was also slightly lower, but I must confess that I didn't manually adjust, neither on the IWellmaster 700 nor on the MS-39, the exact lens thickness. And then ACD is important, had a intra-class correlation of 0.94. And this is known because the IWellmaster 700 is calibrated on the results of the IWellmaster 500. So the IWellmaster will always measure a more shallow ACD. This is important for later in the discussion. So Bland-Altman plots show a very good agreement, but just this offset of the ACD of 0.1 with a deeper measurement in the MS-39. And that, of course, explains why the raw results delivered a more myopic outcome for the MS-39. But then we applied a device correction so that the mean of each device is at 0. And the results after this correction shows a very comparable result between the MS-39 and IWellmaster 700. mean absolute error of 0.36 for both devices with a non-significant difference. The eyes within plus or minus 0.25, 0.575 and 1 diopters are displayed here. And we see very comparable results between both the IWell Master 700 MS-39. As I said, no significant differences between the mean absolute error. But of course, just the lack of a significant difference doesn't imply clinical equivalence. And therefore, we did another test. It's the TOST test, which compares the chance of a difference of 0.125 diopters, which would be the least clinically relevant difference between two devices. If there was a difference of larger than 0.125 diopters, what are the chances that we didn't detect it in this study? So kind of power calculation. And there the p-value was well below 0.001. So in conclusion, there is a clinical equivalence between both devices in predicting IOL power. I also did a sub-analysis for short, medium, and long eyes. I had only very few cases for the short and long eyes, but no differences there. So, in conclusion, the two devices yield clinically equivalent refractive accuracies. Before the optimization, the results from the MS-39 are slightly myopic, which can be explained by the deeper ACD. After this correction, there is no significant difference, with the median absolute error actually being lower on the MS-39. The results are, if I look at plus or minus 0.5 diopters, we are at 65% for the MS-39, 62% for the IWell Master 700. It's not super high. I would have loved higher results, but this is mainly because we used different lenses, also trifocal lenses, and the results were based on auto-refraction, not on subjective refraction. So in conclusion, there is no clinically significant difference in predicting the IOL power between the IOL Master 700 and the MS-39 in routine cataract cases. Thank you.